Guys, I'm going to use some headphones now, so I'm hoping that it will sound better, and I'll try to talk at like a good volume. So, chapter 20, both these chapters are fairly short, 20 and 21. I think I'll get through them in probably 15 minutes. Chapter 20 is about sexual dysfunctions, gender dysphoria, and paraphilias. So, the first thing they want to make sure you understand the basis of sexuality, and that it's a cycle, and at any time you can have issues throughout this cycle that can lead to sexual dysfunction, whether it's an issue in desire, whether it's an issue in excitement or arousal, whether it's an issue in achieving orgasm, whether it's an issue in resolution following. So sexual dysfunctions can occur at any time during the sexual response cycle. So here we go. That's exactly what I just talked about. And also sexual dysfunction can include pain during intercourse, and that can really come and go at any time during people's lives. Sometimes, it can be caused from surgery, from medications, from past trauma. All different kinds of experiences can lead to sexual dysfunction. You have male hypoactive sexual desire disorders. That's where we see like Viagra sometimes being used. Or the inability to maintain an erection. Women can also have decreases in desire, erectile disorder. I'm sorry, that's where we're seeing Viagra being used. Inability to achieve orgasm, delayed ejaculation, so the inability to ejaculate, premature, the inability to some disorder, some of dysfunction can be even the ability to possibly even have penetration before ejaculation. And then pain and penetration disorder, which can be caused by all different kinds of things. So lots of different things can cause sexual dysfunction. It's more common seen in women than men. And often you're going to see it with other kinds of disorders, whether it's obesity, whether it's many, many psychiatric disorders, from depression to all different kinds of things can kind of go hand in hand. And also, a lot of the medications we use to treat psychiatric disorders also can have an ability on sexual function. So we know there's multiple factors, whether it's a biological factor from some sort of hormonal imbalance, psychological factor from multiple different kinds of areas. This is definitely multifactorial, from sometimes how you've been raised, maybe trauma you've had as a child, preconceived notions and ideas and beliefs, religion, all different kinds of things can affect sexual function. And, one of the things that is really important to remember that, if you think about Maslow's hierarchy and where does sex fall on Maslow's hierarchy, this is considered a basic human need. And often you will get patients who oftentimes takes them a little while to get to the point of why they're there and what's happening. Or they may be non-compliant with medications, knowing it's going to affect their sexual function. So for example, many high blood pressure medications can cause difficulty with erection. And so occasionally you'll have patients who aren't taking their blood pressure medication. You're trying to understand why, and you have to kind of ask the right questions. And it's a sensitive topic. However, it's something that it's important when you're assessing a patient that you make sure you look at someone's sexual function too, and is it going okay for them? And everyone's going to have a different tolerance of what is considered okay. And so it can be embarrassing, you can feel discomfort, but you really have to find a way to check that at the door and be open to whatever the patient says, and be open to what they are hoping for, and that this can be a very individualized kind of assessment, as all assessments should be, but it can be very individual as to what patients' goals are, and that can change throughout their lifetime too. So this is something that it really is important that we always, certainly consider this in Maslow's hierarchy. I think at Schwab this summer we saw how, different kinds of levels of paralysis can affect sexual functioning, and just thinking how so many of those young males that we saw, how that must be a huge factor for them. And often it's sort of this unspoken issue, and for many people it may be one of the most important issues for them. So it really is something we want to be aware of. And again, there's all different kinds of ways to deal with this, from just lots and lots, from therapies, from teaching people about their bodies, from different kinds of medications that can help, from couples therapy to, all different kinds of, from actual physical devices for someone who may have some sort of issue that's a more physical kind of issue, when you think of penile pumps and things like that. When I worked in OB and gynecology, a lot of times we would see this in sort of middle-aged women as their hormones are starting to fluctuate. And, it was really trying to teach people about their bodies and helping them to understand. So there's a lot of education that goes into this that can be difficult because of the barriers of embarrassment or preconceived notions, or what people have been taught in their lives, or what they've been taught is okay and isn't okay. And you want to respect people's values and beliefs, while at the same time being as open and honest as you can. So this is where being a non-judgmental nurse is really important, and to do whatever self-assessment you need to do to not bring your own ideas, and judgments as you're talking to someone, because this is a very personal, individual kind of thing. The next topic we're going to talk about is gender dysphoria. And this is what we're looking at when we look at transgender patients. And I found this really interesting because it's in the DSM-5 criteria. And I was with my friend's son, who's transgender, this past weekend, and I was asking him how he felt about the fact that gender dysphoria is in the DSM-5 criteria. And I didn't know if it was something that would be offensive, that it's looked at as a disorder, quote unquote. And he actually agreed. And he said that, that's how you get treatment. That's how you get insurance companies and doctors to take treatment seriously. And so he did agree that, it doesn't mean that it doesn't mean it should be, what's the right word, sort of pushed aside, but that it definitely, he said he was okay with that, because he did feel like something was wrong with him. And the way to get better was for him to identify as a male. So, gender identity, and I feel like the younger generations have a much better understanding of this. So you need to think about, let's say you're taking care of a teen patient who is presenting with some gender dysphoria. There may be a whole different level of education that has to occur to the parents than would possibly have to occur to a teen, right? The parents are going to possibly need a lot more help in understanding what this means. And, you want to take into those generational differences as you're doing that. And that's what we kind of had this long talk about this weekend, about using the proper pronouns, and how to educate with grace, I like to say. And we talked a little bit about that because, and what he said to me is that as long as I can see people are trying, I can have grace. And I like that because, I certainly make the mistake with him sometimes, and I still call him honey every time I see him, but he said that's okay because I call everybody honey, not just girls. But it's really trying to educate with grace and understand that for many in an older generation, this is a big learning curve, and to help them to understand that this is a real issue, and that we really we know that there's a high suicide rate in transgender individuals, and it is so important that we respect and help them to get to the level of comfort that they need. And whether that may just be in how they dress, maybe that is, down the line hormonal treatment, and possibly gender reassignment surgery at some point as well. So as nurses, it's important to help find that comfort level, support it, and offer education that's unbiased and non-judgmental. So gender is your sense of maleness or femaleness. Usually they say you don't really have that sense until up to age 3. And then sorry, my email keeps popping up. And that feelings of unease about maleness or femaleness is that gender dysphoria. And he described his, I asked Sawyer how he felt about the fact that he has female genitalia. I couldn't think of the right word. I would say private parts, like I'm talking to my child, but female genitalia. And he said it disgusts him, and that it truly, in junior high was the hardest time, and that he just absolutely, is disgusted by that. And it really is a gender dysphoria because he does not feel like he's a woman, but he has woman parts and he has to, he gets a period and all those kinds of things. And there's a lot of different stuff that can go into that. It is fairly uncommon. And, we all know, I think you guys know this too, sexuality and gender and orientation are three very different things. There was a good little video that I watched on Psych2Go about that he actually recommended to me that I thought was very helpful and I think could be used as a really good teaching tool, possibly to older generations who haven't had as much exposure to this. Again, it is, it's not real common, to be honest. And again, you may have anxiety, all different issues that come with it. It's kind of the chicken and the egg, which came first, did the gender dysphoria cause anxiety, impulse control problems, or depressive disorders, or was it vice versa? It's hard to say. And again, looking at biological factors, whether it's hormonal differences, psychosocial factors, it's hard. A lot of this is kind of unknown and hard to say. However, again, this is all things, I really just talked about. And again, it's a process, and this is something that definitely doesn't, you don't want a patient to take lightly, especially when you get all the way down to 6 reassignment surgery. And not everyone chooses to do that. And there's lots of steps they go through until they get to that, because you do want to make sure that you're supporting someone and that they're making the right decision. And in order to do that, before that kind of surgery, they do go through lots of therapy and all different kinds of things just to ensure. And usually they're not going to do that until someone's an adult. Okay, the next topic, sexual preoccupations and let's see if I can say this right, paraphilic disorders. This is super interesting. And what I would say is it's things that are considered outside the norm. You can have, like, everything is a spectrum. And this is the kind of disorder that lasts more than 6 months. So it's a pattern of behavior. It's not just kind of one-off, right? It's not a one-off. It's a pattern of behavior that has kind of goes on for more than 6 months. And this is where we really do have that fine line, in that even though it's considered outside the norm, is it okay? And really, when you read the book, they talk about, well, it is okay if it's consensual, if it's not hurting someone, if it's not hurting you, if it's legal, right? It's never going to be okay for an adult to be with the child ever, right? There's never, ever, ever the circumstance that that's okay. Also looking sort of at the power control behind it. It's really never okay with a boss and someone underneath them, because you have this uneven power control. So in my mind, you're not only looking at age, but distribution of power, and who sort of has the control in the situation. Or is it illegal? Is it harmful? Is it hurting? Is it becoming so obsessive that this person can't function? And that's kind of like every disorder we've talked about, is that a lot of us function with probably a little bit of mental illness, and that's fine. Is someone's fetish, interrupting their ability to work, because they're so focused on, whatever their fetish might be, that they can no longer concentrate, that's their only motivation, that they don't find joy or desire in other things. Well, now we've crossed over that line and we've gone way, 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 way past the line into, someone that needs some treatment. However, when you think about it, it's kind of interesting. I'm not sure it's ever okay to illegally display your genitals in public, right? Because you're doing an illegal act that could get you in trouble. But certainly when you talk about different fetishes, again, if it reaches that point of obsessiveness that is interrupting the ability to function in normal society, you've now, crossed a line. These are really interesting. I had to look some of these up. Frotteuristic is rubbing or touching a non-consenting person. No, that's never okay. And so if you have such an obsession to do that you can't function, that's all you think about, you definitely need treatment. Pedophilia is really one of the most common of the paraphilic disorders. It's not that it's incredibly common. Probably, in my mind, one of the most disturbing and just very, never ever okay, definitely needs major treatment, is difficult to treat, to be honest, which is why we have such, the sexual predator, I can't think of what that's called, registry. But when we're talking about pedophilia, we're looking at someone who's interested in that prepubescent children. So people under 13 who really haven't gone through puberty yet. And we'll talk a little more detail about all different kinds of things we think can lead to that disorder. Sexual sadism, achievement of sexual satisfaction through physical or psychological suffering of the victim. I don't know. I mean, is that ever okay if the victim is willing? Is the victim a masochist? So, right, then you look at sexual masochism, which is an achievement of sexual satisfaction by being humiliated, beaten, bound, or made to suffer. So if you have a sadist with a masochist, and this is how they both achieve sexual satisfaction, and no one's being harmed to the point of lasting, I don't know. I don't know. I just don't know what the right answer to that is, other than mutually consenting adults, I guess. Um, Disrupting daily life, unable to function because all you're thinking about is this. I don't know. It'd be interesting to maybe we'll have a little bit of a on Monday. We'll spend a little bit of time just kind of discussing. I don't know. I don't really know the answer to that. I have to think about that a little bit. And then transvestic disorder, I find interesting. It's people who have sexual satisfaction through dressing as clothes of the other gender, and it often starts in children, I guess. But it's not considered gender dysphoria because it's not that they want to be part of the other sex. I don't know. Does it matter if someone is doing this? I mean, does it harm anyone? Could it be the sign of a deeper problem? Is it sometimes? Maybe. I don't know. So peeping Tom is when you think of voyeuristic disorder. This is someone who's spying on someone. And yeah, that's going to be a problem because that's illegal and that breaks boundaries and that's, not okay. So, oh boy, you guys can go through all of this stuff. Some of this stuff, again, I don't know, consenting adults, I don't know, or is it too, it's hard, or is someone being made to have feces put on them or be urinated on or be, strangled during sexual intercourse, or I don't know, I would think phone calling is probably never okay because you're basically, putting that on someone else, right? Which I think would be, somewhat of a sexual assault kind of behavior. But I think we're going to talk about this because I don't really, I'm not sure it's ever okay to incorporate animals or necrophilic. I think that's illegal. I think both of these are illegal because we know that's harmful and they can be signs of deeper problems too. And an animal cannot be a consenting partner, so that's never going to be okay. So I don't know. They said, I found this super interesting, somewhat rare, but because even though they're rare, people who have, oh gosh, sorry, Friday emails, people who have fetishes, as my husband says, if there's a Reddit for it, it's something like if there's a fetish, there's a Reddit for it or something. I mean, you can really go, boy, there's a lot out there on the internet. But because people who have fetishes repeat it a lot and it can become consuming to them, it does seem to occur more frequently in a healthcare setting. You may see that. Comorbidity with it could, you can have anxiety, you can have ADD, you can have depression, chicken before the egg, not sure which one. Sometimes you'll see this in people who have head trauma, where all of a sudden they lack inhibitions and you'll see inappropriate sexual acting out. What do we call that? ISO, inappropriate SAO, sexual acting out. So it's not uncommon to see sexual acting out in someone who is kind of lost touch with reality or has impulse control issues or has some, all different kinds of things that SAO is not uncommon to see. Certainly past experiences can play into all of this, why you maybe have a certain fetish. Lots and lots of different things from the past can affect how we are in our future. So you want to definitely, when you're assessing, make sure that they are not harming themselves or others. And you want to, like I said, when I talked about that power struggle, that's where we're looking at victims versus active agents. Is this someone who wants to be in this and they want to do it? Or is this someone who doesn't? And this is when you need to really check yourself, because even though it's behavior that maybe you wouldn't want to participate in or you feel judgment towards, if they're actively participating in it and they're consensual and it's not harmful, we need to respect autonomy of people and keep our judgments to ourselves. So if they have a current illness that's brought on by this behavior, so they're, doing something that's causing then a physical illness, like a perforated bowel because they have a fetish with putting inanimate objects up their rectum that aren't made for that, then you have a problem, right? And you need to really try to figure out, how you can help this patient with that problem, because they cannot continue to perforate their bowel, and that can be super dangerous. Those are things I have seen. You always look at suicide, always look at other directed violence, right? Are they possibly harming other people? Is there a way to help them to achieve a more healthy sexuality pattern? But again, what do I always say? Your very first focus is safety and crisis intervention. So how do we keep this patient safe? Are they in crisis? Are they suicidal? Is there someone else being harmed that needs to be addressed? All of those kinds of things. And again, you're going to look at all different kinds of, interventions, from therapy to possibly SSRIs to possibly, it's hard to say, all different kinds. You might be treating some of those comorbidities. They need to do some psychotherapy. And when we think about psychotherapy, we think about delving into our past and looking at what's going on, because a lot of times past experiences can contribute to this. So lots of different things to look at. Very interesting. I actually talked a little longer than I thought I would. Happy Friday. And